They are very, very small. We used to work with Wolf and Wolf Company. I think it's been sold in this country as well. They mainly make human material these days and not anymore veterinary material they make, which is a pity, but they had very nice tools. But now these days also Artrex, Leibinger have very nice small tools like a kind of the palpator, a kind of forceps in different sizes, different teeth in the grasping forceps. So Artrex these days and Leibinger have very nice instruments available. Also scopes they have, so I think you have to look in these brands.
Спасибо. Следующая наша тема – это чтение снимков, интерактивная оценка различных случаев согласно структуре IEWG. Часть первая, через перерыв будет часть вторая.
So we will change a little bit here our position. Okay, I will just briefly say some words about the interpretation of the ELBO working group. Yesterday, Professor Razewinkel, I think, showed these images as well about the specific areas in the elbow joint where we are looking for new bone formation, the area of the sclerosis we have been talking already. Then the blue arrow here is pointing at the medial humeral condyle, and this area is where we see new bone formation in cases suffering from flexural pathology. So it's not a part of arthrosis or osteoarthritis, it's a reaction that at this part of the bone in cases where there is inflammation or pathology of the flexural tendons. So the grading of the elbow arthrosis is also been shown yesterday, the different degrees of osteophytes that we find, the different heights of osteophytes, concluding that we are dealing with one of those 4 grades of ED. And then the borderline cases that are the difficult ones, the ones that have some sclerosis, whereas really minimal reaction at the anconeal process, and where we are not sure whether we would give this elbow a 0 or a 1. So we can conclude that we are dealing with a borderline. That's an extra group that might exist in some cases. So the primary lesions in the grading are easy in that way that the lesions are graded as absent, healthy is grade 0. In cases suspected of the presence of a medial coronoid process, they are immediately graded 2. Even if they have very small osteophytes that you would say, okay, it's a 1, but if the sclerosis is really present and you are almost sure that there is a coronoid pathology, then they are graded 2 already. And then cases where we see the primary lesion, they are immediately graded 3. Also in cases where a limited amount of osteophytes is present. But when you really see the fragments at the level of the medial coronoid process, or you immediately see the defect at the medial humeral condyle, they are immediately graded 3. So this is the scheme. The normal elbows, of course, the grade 1 with a limited height of osteophytes and some sclerosis. The grade 2, the osteophytes are higher, and also cases, that's better, where obvious sclerosis is present, where you might have the suspicion of having the presence of a medial conoid process. They got a grade 2 already. And then, of course, the 3, where the height of the osteophytes is very high, and or where an obvious lesion, a primary lesion, is present. And what are the primary lesions? The ununited enconeal process, the fragmented conoid process, and the OCD. Okay, we've been talking about CT extensively already. So, second advice, diagnostic imaging examination, CT, is in cases where owners ask for second advice for the result that they gained from the breeding club or the FCI or the whatever. So in doubtful cases, CT is recommended, and I already talked about the application. We made the standardized procedure. Here we have nicely how the images are obtained at the level of the medial conoid in or position. You see, it's not completely the same level. If we position the dog in lateral recumbency, it might happen that we have a little bit this. It means that if we take the same plane on CT, that we see a little bit a different image, meaning that we are a little bit in a different plane. That doesn't matter. What's important is that they are quite close to each other, that we see in this image. Again, will obtain or result in better images. So this is the scheme we made. It will be published and accepted soon, where the CT findings are scored in doubtful cases. Radiographs remain the tool for diagnosing arthrosis. So that's something that we agreed for. We will not, we can of course, visualize and diagnose arthrosis on our CT images, but the height of the osteophytes, the scoring of the osteophytes, still will be the responsibility of the radiographs. So CT is to extra visualize the conoid process, and what's important is that there are some miscellaneous findings, like the flexor tendon pathology. It's not included in ED, it's a separate pathology. We will talk about it later more extensively. The avulsions of the epicondyle, which we might see in young animals, is also not a part of ED. And the incidence of incomplete ossification of the humeral condyles also not. So this is, however, it is a hereditary disease, the incomplete ossification in specific breeds. It's not included in ED, so that's important as well. This is the position. It can be in the thoracic positioning, but always try to keep the head outside the gantry. Then something more about sclerosis, as it's difficult often to visualize or to standardize the sclerosis. We have seen those images where it's quite clear, the increase in brightness, in density, when you compare it to the normal trabecular pattern. Which might be helpful is if you check the dark gray intramedullary region of the ulna, and I will show it. Sorry. This is a normal elbow, and here we have some brightness, so some sclerosis. If we evaluate the dark intramedullary area of the ulna, And imagine those lines. Try to follow the delineation of the medulla. When it narrows, as we see here, we are sure we are dealing with sclerosis. So more or less it needs to be parallel, remain parallel those lines we imagine, in order to be sure we are not dealing with sclerosis. Sorry. So it might be helpful, and of course secondary, check the outline of the conoid process as we did before. And if we compare this delineation with this one, there's a small bump, a small bulge. So this is also abnormal. Okay, then we go to the first case. It's a German Shepherd, very popular breed in all countries. I know you have Shepherd breed dogs here a lot as well, but they are larger, about 60 kilos. I heard, so first we will look to the X-rays. And I will adapt. Is that okay? If there's a volunteer in the room, I have a second pointer. Are volunteers I know well in the room, or maybe they could be volunteer. So what about this elbow? Is it normal? On top we have the right elbow, below the left. We can measure. It's 2.67. Who says ED 0? Okay, well tried. ED1, ED2, ED3. No one? If we look to the delineation of the bones itself, we see particular areas having new bone formation, certainly on the anconeal process here, also in the cranial part of the radial head. What about sclerosis? Is there sclerosis? No. Who says no? Who says yes? If we try to follow our medulla, Imagine the lines. Would it narrow? I think so. The lines would be, and here as well. It's too bright, too much trabecular pattern. There is sclerosis. What about the delineation of the coronoid? Is it triangular? No, it's not triangular. In both joints is not. This one is blurred, irregular, delineated, inhomogeneous, certainly there. On the craniocaudal, we see the medial humeral condyle. Looks well, it's not flattened. Maybe that we could find some kissing lesions here. Here as well. This area, it's not okay. So, are we dealing with a normal coronoid, or are we having suspicion for a primary lesion? Who says ED1? Who says ED2? There is a suspicion of a non-displaced, or at least a non-displaced, I can't say, but the abnormality of the medial coronoid process is clear. There is new bone formation, more than 2 millimeters, sclerosis, but there's a suspicion of a primary lesion. So we are not really sure, but really suspicion. So it's an ED2, this would be. I also have the CT images. Immediately see new bone formation at the level of the medial humeral condyle. Also here, irregularity. The osteophytes. We are going down in the joint, going to the articulars, joint space. We see already sclerotic area here, and here we see the joints are nicely positioned parallel, close to each other, but not on the same level. But that's okay. You just visualize one elbow after another. But if we look to this one, and we are in the area of the surface of the medial coronoid process, we see multiple fragments. One larger, few smaller, blunt delineation of the coronoid process. In the left one, we always position left lateral recumbency just to standardize that we always know the one below lying on the table is the left one, the one in the air is the right one. So we check the right, go down, and we see a huge displaced fragment. A large one and a smaller in this area. This is all medial coronoid process, new bone formation. This is the head of the radius. Head of the radius. We go up a little bit, and if we look to the medial humeral condyle of the right one and of the left one, it's not having an homogeneous density. So it will be having kissing lesions, this elbow joint, due to the fact that the displaced fragments move to the cartilage and cause damage of the cartilage. We know that this is not OCD, but really secondary stripes in the cartilage. So the conclusion on CT would be ED3. Okay, everyone agrees? Any questions? Then we go to case 2. A large Swiss Sennen dog, it's like a Bernese mountain dog, but larger, shorter hair, of 18 months. And this was an official control, official screening for breeding. case from abroad, so there are only two positionings available, the lateral 45 degrees and a craniocaudal over-rotated image. What about the quality of these images? The positioning of this one is over-rotated. It's too oblique. It's really, the ulna is crossing the humeral condyle, so it should be craniocaudal, a little bit obliquity of 15 degrees in order to visualize well the medial compartment. So this is the medial compartment. We can see it well, but to be strict, it's not a perfect position. What do we think? This is the right elbow. Is there arthrosis? Is there sclerosis? What about the coronoid? Is it abnormal?
Yes.
What's abnormal?
Medial epicondyle. Humeral. No. That's good.
Medial epicondyle. I stay fit.
You think the medial epicondyle is abnormal in this area? You mean in this view?
Lateral view.
This is indeed, you are right.
Yeah,
I'm
yeah.
sorry. Yeah, this is abnormal. It's new bone formation, small new bone formation at the medial humeral condyle. This is the lateral one, the one with the curve. Superimposed is the lateral humeral condyle. This is the medial one. Is there sclerosis? No. Nice delineation of the medial coronoid. What does it mean, this new bone formation?
Flexor tendon.
Flexor tendon, you are right. I don't have to lecture anymore because the next presentation will be going about flexor tendons. You know everything already. This is the spur, it's a skeleton ingrowth at the level of the attachment of the medial flexor tendons, where the skeleton is growing or producing new bone formation in the attachment. The enthesis, it's been called, the attachment of the tendon to the bone. A spur, we see that in humans as well, and it's a typical finding in dogs to point out that there's something, might be something with the flexor tendons. Okay, perfect. Is this ED3? ED1? ED0? Who says 1? Who says 0? It was scored officially abroad as having a grade 2. So we have the right elbow, this is the left. There's also some discrete reaction at the level of the tendons. No sclerosis, normal coronoid process, normal area. Okay, we go. Often it helps if we put a wedge in between both elbows in order to keep them parallel to the table, parallel to each other. Otherwise, it might have that the one above, the right one, rotates a little bit. So it's helpful to use the wedge. If we look to the delineation of the bones, it's perfectly delineated. No new bone formation. This is the cranial part of the radius, medial condyle, lateral humeral condyle. conoid process, homogeneous, well delineated. If we look to the right one, there is new bone formation at the level of the caudal and distal part of the medial condyle where the flexing tendon attaches, some sclerosis, and in this one the same, a little bit irregular delineation, sclerosis, and in the left we even have a calcification in the flexor tendons. So this should have an ED0. The tendons, as we run always both algorithm, the bone and the soft tissue algorithm, are also not swollen. We can pick up the tendons at this side, and however there is a calcification present, so it looks very quiet. So this elbow should have, or both elbows should be diagnosed as ED0. So this is a second opinion CT because the owners did not agree with the results. This is a golden retriever, 20 months old. Again, the three views of the right elbow. What do we think about the delineation of the bony structures? What about the quality, technical quality of the positioning? So as I said, in Belgium, also for official screening, we make 3 views. I think this one is hyper-flexed. It's really in a maximal flexion. That's too much. So it should be 60-degree flexion. I know you handle 45-degree flexion for the lateral view, mediolateral. We do normally between 45 and 60 and then a real extended. So this could be better. What about the exposure? Is that okay, this one? This one more or less okay, this one is okay. Underexposed, okay, too bright. What about the left? The same positioning, so also too flexed. We already, I think, can conclude there's no new bone formation. The delineation is okay of the conoid process. Also in the previous case, I think we can conclude there's also no sclerosis. Does everyone agree with ED0? Okay. Who says ED1?
Yeah.
Why?
Medial epicondyle craniocondyle projection.
Medial epicondyle? You see something?
Stay
I don't get a translation, I'm sorry. New bone formation.
Maybe incongruence.
And incongruity. If we look to this image, you see how nicely the joint space is, the fitting of the humeral condyle in the notch. No step, no enlarged joint space between humerus and radius, and also I think here we can conclude it's a normal congruent joint. On the radiograph, we actually best visualize congruity or incongruity on a lateral extended view and secondary on the craniocaudal. The flexed is usually not useful to visualize incongruity. I think it's a very nice joint. If you look this one and this, it's a nice fitting elbow. He got an ED0. I think we can agree with it. Okay? Case 4. 11.5-month-old Labrador Retriever. So in theory, for official screening, he's a little bit too young. He needed to be 12 months old. But anyway, so the left on top, the right